Imagine a patient arrives in the emergency department with pinpoint pupils or what we call miosis. At first glance, based on what we have already discussed in cholinergic pharmacology, we might think that this is due to stimulation of the parasympathetic nervous system. For example, exposure to an organophosphate compound leading to excessive muscarinic activity. But what if I told you that the exact same finding could also occur when the sympathetic nervous system is blocked? Now consider another patient who presents with dilated pupils or mydriasis. Based on our previous discussion of the adrenergic system, we might assume that this is due to sympathetic stimulation. However, could the same finding also result from blockade of the parasympathetic nervous system? This creates an interesting challenge. When we observe a change in pupil size, we cannot immediately determine which autonomic pathway is responsible. The same ocular finding may be produced by different autonomic mechanisms. So the real question is, when a patient presents with miosis or mydriasis, how can we determine whether the underlying cause is cholinergic activity or adrenergic activity? In this session, we'll answer that question by exploring how the sympathetic and parasympathetic nervous systems regulate pupil size, accommodation, and intraocular pressure. Now, before we can answer these questions, we first need to understand what the autonomic nervous system actually does in the eye. One of the most important functions of the pupil is to regulate the amount of light entering the eye and reaching the retina. If too little light reaches the photoreceptors, important visual information may be missed. On the other hand, if excessive light enters the eye, the photoreceptors can become overstimulated, making vision less effective. Therefore, the size of the pupil is constantly adjusted to allow the right amount of light to enter the eye. To achieve this, the iris contains two sets of smooth muscles that work in opposition to each other. The first is the circular muscle, also known as the sphincter pupillae. As the name suggests, these muscle fibers are arranged in a circular fashion around the pupil. Therefore, when this muscle contracts, it constricts the pupil, producing a small pinpoint pupil, a phenomenon known as miosis. In contrast, the iris also contains a second muscle called the radial muscle or dilator pupillae. Unlike the circular muscle, these fibers are arranged like the spokes of a wheel, extending outward from the pupil. Consequently, when the radial muscle contracts, it pulls the iris outward, increasing the diameter of the pupil and producing pupillary dilation, a phenomenon known as mydriasis. Therefore, pupil size is determined by the balance between these two muscles. Under normal circumstances, we do not consciously adjust our pupil size in response to changing light conditions. Instead, this regulation occurs automatically through the autonomic nervous system. Now consider a situation in which the body is experiencing a fight or flight response. During such moments, the brain wants to gather as much information as possible from the surrounding environment. To achieve this, allowing more light to enter the eye would be beneficial. Therefore, it makes sense that the sympathetic nervous system promotes pupillary dilation or mydriasis. Since mydriasis occurs through contraction of the radial muscle, thus radial muscle must be under sympathetic control. More specifically, this effect is mediated by alpha-1 receptors. As we have already discussed in previous lecture, alpha-1 receptors are GQ-coupled receptors that increase intracellular calcium, leading to smooth muscle contraction. Consequently, stimulation of alpha-1 receptors causes contraction of the radial muscle, resulting in pupillary dilation or mydriasis. On the other hand, when we're resting comfortably and not facing any immediate threat, we don't need to maximize the amount of visual information entering the eye. In such situations, the parasympathetic nervous system takes over. Through M3 receptors on the sphincter muscle of the iris, it causes contraction of the sphincter muscle, resulting in pupillary constriction or miosis. So stimulation of M3 receptors contracts the sphincter muscle and produces miosis, whereas stimulation of alpha-1 receptors contracts the radial muscle and produces mydriasis. Consequently, muscarinic agonists produce miosis, while alpha-1 agonists produce mydriasis. However, this leads us to another important concept. So far, we have focused on receptor stimulation as a way of changing pupil size. For example, stimulation of M3 receptors produces miosis, while stimulation of alpha-1 receptors produces mydriasis. But receptor stimulation is not the only way to produce these effects. Think about it logically. If alpha-1 receptor stimulation causes contraction of the radial muscle and produces mydriasis, then blocking alpha-1 receptors would prevent the radial muscle from dilating the pupil. As a result, the parasympathetic influence on the sphincter muscle becomes unopposed, leading to miosis. Similarly, if M3 receptor stimulation causes contraction of the sphincter muscle and produces miosis, then blocking M3 receptors would prevent pupillary constriction. In that situation, the sympathetic influence on the radial muscle becomes unopposed, resulting in mydriasis. Therefore, miosis can be produced in two different ways, either by stimulating M3 receptors or by blocking alpha-1 receptors. Likewise, mydriasis can also be produced in two different ways, either by stimulating alpha-1 receptors or by blocking M3 receptors. Consequently, whenever we encounter miosis or mydriasis in a patient, we must consider at least two possible autonomic mechanisms before reaching a conclusion. At this point, you can probably appreciate the challenge. If both miosis and mydriasis can be produced by two different autonomic mechanisms, then simply looking at pupil size may not be enough to identify the underlying cause. Therefore, if we want to distinguish between miosis caused by an M3 agonist or by an alpha-1 blocker, or between mydriasis caused by an alpha-1 agonist or by an M3 blocker, we need to look for another clue. Fortunately, there is another ocular function that can help us make this distinction, and that function is accommodation. Accommodation has nothing to do with changes in pupil size. Instead, accommodation refers to the eye's ability to adjust its focus, particularly when shifting between distant and near objects. This process is primarily controlled by the ciliary muscle. Anatomically, the ciliary muscle is connected to the lens through a series of suspensory ligaments, also known as zonular fibers. Normally, when we are looking at a distant object, the light rays reaching the eye are nearly parallel. To focus these rays precisely on the retina, the lens remains relatively flat. At the same time, the pupil is relatively larger, allowing sufficient light to enter the eye and provide a clear image of distant objects. However, imagine that you suddenly shift your gaze from a distant object to something very close to your eyes, such as a book or your mobile phone. In this situation, the incoming light rays are more divergent and can no longer be focused properly by a flat lens. Therefore, the eye must make certain adjustments to maintain a clear image. This process is known as accommodation. During accommodation, the ciliary muscle contracts, which reduces the tension on the suspensory ligaments attached to the lens. As a result, the lens becomes more convex or more spherical. This increase in lens curvature enhances its refractive power, allowing the divergent light rays coming from a nearby object to be focused accurately on the retina. At the same time, the pupil also constricts, helping to improve the sharpness of the image and reduce optical aberrations. Together, these adjustments enable us to see near objects clearly. Therefore, accommodation can simply be defined as the process by which the eye changes the shape of the lens to maintain clear vision when shifting focus from distant objects to nearby objects. So, when the ciliary muscle is relaxed, it pulls on the suspensory ligaments, increasing the tension on the zonular fibers. This tension stretches the lens, making it flatter and is therefore better suited for focusing parallel light rays coming from distant objects onto the retina. In contrast, when the ciliary muscle contracts, the tension on the zonular fibers decreases. As a result, the lens is no longer stretched and becomes more rounded or more spherical. Consequently, we are able to see near objects clearly. Unlike pupil size, which is regulated by both the sympathetic and parasympathetic nervous systems, Accommodation is controlled exclusively by the parasympathetic nervous system. Therefore, ciliary muscle contains muscarinic receptors, predominantly M3 receptors, but it does not have any significant role for alpha-1 receptors in the process of accommodation. In fact, this arrangement makes perfect sense. Imagine that accommodation were under sympathetic control. During a fight or flight response, sympathetic activation would force the eye into a particular accommodative state. As a result, you might be able to see either distant objects clearly or nearby objects clearly, but this would make it harder to quickly shift focus between near and distant objects. This could become problematic in a dangerous situation where you may need to look at a nearby obstacle one moment and a distant threat the next. Therefore, it is beneficial that accommodation remains under parasympathetic control, allowing the eye to adjust its focus as needed. Now, since accommodation is controlled entirely by parasympathetic nervous system, so naturally only muscarinic drugs can affect accommodation. In contrast, alpha-1 agonists and alpha-1 blockers may change pupil size, but they have no significant effect on accommodation. This distinction becomes clinically important because changes in accommodation often lead to blurred vision. Let's consider what happens when muscarinic receptors are stimulated. A muscarinic agonist causes contraction of the ciliary muscle, which reduces tension on the zonular fibers and allows the lens to become more spherical. As a result, the eye becomes focused on near objects, a state sometimes referred to as a spasm of accommodation. Consequently, objects that are close can be seen clearly, whereas distant objects appear blurred. On the other hand, when muscarinic receptors are blocked, the ciliary muscle cannot contract and remains relaxed. As a result, the lens stays relatively flat. In this situation, the eye is better suited for viewing distant objects, but it loses the ability to properly accommodate for near vision. Consequently, distant objects remain clear while nearby objects appear blurred. Now let's see how this principle helps us distinguish between different autonomic mechanisms. Suppose a patient presents with miosis. As we discussed earlier, this finding could result either from stimulation of muscarinic receptors or from blockade of alpha-1 receptors. However, if the miosis is accompanied by accommodation for near vision, meaning the patient can see nearby objects clearly but distant objects appear blurred, then the cause must be muscarinic stimulation. On the other hand, if miosis occurs without any change in accommodation, then an alpha-1 blocker becomes the more likely explanation. Similarly, consider a patient with mydriasis. Again, there are two possibilities: either stimulation of alpha-1 receptors or blockade of muscarinic receptors. The key is to look at accommodation. If the patient has difficulty focusing on nearby objects and can only see distant objects clearly, this indicates loss of accommodation, a condition known as cycloplegia. In other words, the eye is unable to accommodate for near vision. Since accommodation depends entirely on muscarinic receptors, the presence of cycloplegia immediately points toward muscarinic blockade. In short, blurred vision is a hallmark feature of muscarinic drugs. Therefore, whenever a change in pupil size is accompanied by a change in accommodation, whether the patient sees near objects clearly and distant objects poorly, or distant objects clearly and near objects poorly, we should think of muscarinic receptor involvement. In contrast, if the pupil size changes without any blurred vision, the underlying mechanism is more likely related to alpha-1 receptor activity. Now, by taking advantage of this discussion, I would like to discuss another important topic that is closely related to what we have just learned, that is, muscarinic drugs in glaucoma. As we discussed, stimulation of M3 receptors causes contraction of the ciliary muscle. Interactingly, when the ciliary muscle contracts, it also exerts traction on the trabecular meshwork located at the iridocorneal angle. As a result, the pores within the trabecular meshwork open up, allowing aqueous humor to drain more efficiently into the canal of Schlemm. Consequently, the outflow of aqueous humor increases, leading to a reduction in intraocular pressure. Therefore, by promoting ciliary muscle contraction, muscarinic agonists not only produce accommodation and meiosis, but also enhance aqueous humor drainage and lower intraocular pressure. This is one of the reasons why cholinergic drugs have an important role in the management of certain types of glaucoma. Now, while discussing glaucoma, it is important to remember that intraocular pressure is determined not only by the drainage of aqueous humor, but also by its production. So far, we have focused on increasing aqueous humor outflow through contraction of the ciliary muscle. However, there is another way to reduce intraocular pressure, by decreasing the formation of aqueous humor itself. In this regard, beta receptors present on the ciliary epithelium play an important role. Stimulation of these receptors promotes the secretion of aqueous humor into the eye. Therefore, if we block these beta receptors using beta blocker drugs, the production of aqueous humor decreases. As a result, less fluid accumulates within the eye, leading to a reduction in intraocular pressure. Therefore, while muscarinic agonists lower intraocular pressure by increasing aqueous humor outflow, beta blockers achieve the same goal through a different mechanisms, by reducing aqueous humor production. Ultimately, both approaches help lower intraocular pressure and can be useful in the management of glaucoma.